Good morning, everyone. Thanks for joining us. Just wanting to acknowledge this morning that we are on the unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh First Nations. I'm Victoria Schmid. I'm the CEO of Switch, and I am really excited to be the moderator for this session today. As Courtney was talking about this morning, the best steps forward for us for climate change are around preparation, and I'm so excited to hear these groups share their learnings with us so that we can start that preparation and start that movement as we move forward to prepare for the climate change future that we have. The rapid fire session today will be 10 minutes of presentation, 8 minutes for question and discussion, and then 2 minutes for transition. So we'll go ahead and get started with our first one.
Good morning, folks. My name is Anna. I'm the research coordinator for the CORIG-funded CEDARR study at the UBC Centre for Rural Health Research. And today I'd like to introduce to you the CEDARR Canada study. We were looking at lessons learned from COVID-19, responding to climate change and ecosystem disruption in rural Canadian communities. So I gratefully acknowledge today that we're presenting from the Coast Salish territories and that the CEDARR research was conducted in rural communities on Indigenous territories and lands across Turtle Island. This project has received financial support through the COVID-19 Pandemic Response and Impact Grant Program, organized by the Foundation for Advancing Family Medicine and the Canadian Medical Association Foundation. I have nothing to disclose. The objectives of today's presentation are to outline the program of research and preliminary results from the CEDARR study and to create an opportunity for dialogue about CEDARR findings and recommendations. So the CEDARR Canada study is the climate change and ecosystem disruption adaptation responses in rural Canadian communities. And we are trying to see what has the COVID-19 pandemic taught us about rural community resilience in Canada, and how can these lessons be translated to support resilience in the face of climate change and other future ecosystem shocks? This was a qualitative study. We conducted virtual semi-structured interviews. We had 64 interviews conducted in 22 Canadian communities. Our participants included 27 physicians and 8 healthcare team members. We had 7 communities in British Columbia, 7 communities in Alberta, 2 in Saskatchewan, and 6 communities in Ontario. We also conducted a series of 6 community forums where we returned our findings to the community, really as an opportunity to reflect and obtain feedback on our results to see if we got this right. As a brief snapshot of our project timeline, we received successful funding in June of 2021. I joined the team alongside our research assistant, Alex, in October. And this is when we initiated recruitment of rural communities across Canada through both our co-investigators and through Society of Rural Physicians of Canada contacts. So these were seed contacts in the communities that through snowball sampling then referred us to other community members. And what we tried to capture through CEDARR was that rural physicians are an important part of community resilience, but by no means the end of the story. So we spoke with grocers, we spoke with councillors, with mayors, really trying to obtain a broad picture of community resilience. November to January, we had ongoing recruitment and data collection through these case study interviews. February to March was an opportunity for data analysis. This was a major study, close to 1,300 pages of qualitative data, so we were fortunate to have a large team of coders supporting this analysis. And this is also when we conducted those virtual community forums to obtain feedback on our findings. In April, we presented at the Society of Rural Physicians of Canada conference in Ottawa, ran a series of 5 workshops there, and then in May, we initiated our demonstration community phase, where we hope to work with new communities trying to implement some of these recommendations that emerged from CEDARR and translate some of these strategies and innovations that could support rural community resilience in other settings. From now until December, we have ongoing knowledge dissemination activities and preparation for publication. So the first theme I'd like to introduce to you today is that of health service delivery. And a main point that I'd like to highlight from this slide is the role of physician payment models. particularly those that best support broad social accountability. And so in rural British Columbia and across Canada, we found that physicians endorsed alternative payment models in many settings. So these are models that provide a salary or a blended capitation approach in contrast to those that offer fee-for-service approaches. And APP models that provide these salaries can support work-life balance for physicians, relationship building with patients, and the ability to be remunerated for their time involved in pandemic response activities or in response to ecosystem disruption preparation in ways that fee-for-service models may be less supportive of. And then in terms of continuity of care and implications for trust building, participants emphasized the strength of a family health team approach. They spoke to the strengths of team-based primary care, with quality improvement and resilience really being grounded in those longitudinal, trusting relationships between care providers, with patients, and with the healthcare system more broadly. And I believe many of you may have had the opportunity to attend the spirited debate yesterday on virtual care. And I will say in our study as well, just as we had mixed perspectives on the optimal physician payment models, we certainly heard mixed perspectives on virtual care as well. There were concerns expressed that when the Ministry of Health changed fee codes for virtual consultations, the large virtual care platforms such as Babylon or Maple were able to bill the same for consultations as family physicians that offer full service, longitudinal relationship-based care. And that this potentially undermines that full service family medicine, which has in so many ways been at the foundation of rural practice. That being said, I'm sure we're all familiar with the advantages of virtual care in terms of improving access to care. Don't need to rehash yesterday's debate arguments to you. But certainly in providing home-based care where patients can remain near their support networks. So we do want to take a nuanced approach to how we present the advantages, disadvantages of both payment models and virtual care approaches. And then in terms of cultural safety and humility, physicians wanted to ensure that they were co-creating health solutions with Indigenous partners with a focus on patient-centered service delivery. This includes ensuring that culturally competent care is available, with providers understanding, for example, the legacy of the residential school system and being able to engage appropriately with the lived experiences of their Indigenous patients. So a key recommendation emerging here is to develop rural health service models that support that continuity of care and the flexibility for providers to engage in community sustainability activities. Again, facilitating that through the alternative payment models that can support that broad social accountability in rural settings. The next theme I'd like to introduce is relationship building, which was really at the heart of what CCEDARR recommendations developed. We found that trust in physician leadership was really grounded in that relationship-based healthcare. And an important dimension of leadership was community consultation in decision-making. Certain participants expressed concerns that there were mandates or closures that seemed to be designed with large urban centers in mind rather than consideration for the specific differences and unique capacities of rural communities. So taking into account that you need community consultation, that the cookie-cutter solutions that are sometimes implemented at a provincial level may need a more decentralized approach or a consideration for specific unique characteristics of rural settings. Participants also highlighted the strength of a bottom-up approach to leadership. They emphasized the need to listen and learn from the community and to adapt resources to best serve its members. We heard that part of building those trusting relationships in team-based care settings is seeking to flatten hierarchy and really making sure that all voices on your team are being heard and given equal weight. The next point there is on volunteerism and not-for-profits. We heard of incredible examples being supported by the Columbia Basin Trust in the Kootenays. If anyone is familiar with that, there's incredible work being done in Kimberley in terms of a food recovery depot program supported by Healthy Kimberley, where not only food security is ensured for the community, but it's an opportunity for social connectedness and for the community to really come together as one during the pandemic or during challenging times. And then many of these rural communities also demonstrated a strong not-for-profit ethos. So an example there is in Fort St. James. Their primary care society model runs as a not-for-profit, I believe, as well as their ski hill, a golf course, a curling rink, all of which operate on these not-for-profit models that has demonstrated tremendous success in several settings. And then we do also have a youth committee as well as an Indigenous advisory committee guiding our research engagement through CCEDARR, really prioritizing here the voices of future generations when it comes to adopting a climate resilience perspective and trying to learn from Indigenous knowledge keepers when it comes to respectful engagement with Indigenous communities according to OCAP principles. Recommendation emerging from this theme is to establish a provincial rural community symposium to share these innovations and strategies that foster collaborative approaches to rural sustainability. The final theme I'll share with you today is that of communication and advocacy. So community connection, we found, primarily occurred through Facebook during the pandemic. Participants spoke to the ease with which they could be learning about public health messages, including daily case counts, the directives, but also as a means to keep in touch with their community members while physically distancing. There were, however, concerns expressed related to anti-mandate or anti-vax sentiments on open forums, on Facebook comments, even on clinic pages. A potential solution to this we saw through Waal, Ontario, where the community had already established a popular online bulletin that made it easier to streamline public health messaging and circumvented some of that negativity that can accompany open public forums such as Facebook. We heard of very interesting examples for avenues for youth advocacy, so including the Kimberley Youth Action Network, and in Drumheller, Alberta, there's an opportunity each year for youth to sit on town council. They're voted in and they really have an opportunity to participate in the decision-making processes. And we found that enhancing community resiliency ultimately requires addressing the social determinants of health. So beyond concerns related to food security, as I spoke to, we heard across rural British Columbia major concerns related to affordable housing. And an important point that I don't think we had appreciated fully at the start of this project would become such an important sub-theme was that of mental health. And providers expressed across rural settings a major concern that youth mental health and substance use became a major burden with a lack of resources during the pandemic. And finally, rural physicians also had an important role to play in climate action and emergency preparedness, as Dr. Howard spoke to this morning, specifically in preparing those evacuation plans and preparing for things like wildfires and floods, certainly required advanced preparation and planning on the clinic and physician side of things. So a key recommendation emerging from this was to establish a network of rural community communication to ensure timely and appropriate information sharing both within and between rural communities. Thank you very much. I invite any questions and connect with myself or Dr. Grzybowski.
I work with Fraser Health, and I am a change lead for social prescribing in this area. And one of my questions to you is, did you consider looking into the coordinating efforts of a community connector, rather than the emphasis being on the users of the system to contact these services in their communities, having someone in the community actually help and enable to connect to these vital services so that people have less isolation and less of that perhaps stigma that can happen following COVID. You mentioned a little bit about that on social media and so on and so forth. Was there any efforts made to look into that role in these rural communities?
Yeah. No, it's such an important point. I think that onus is not only on the patient or this community member. Something I might point to is an important recommendation that emerged was establishing a volunteer liaison position. So we found that there wasn't necessarily a designated community member who had a handle on all of the social connection opportunities available in the community, and establishing an individual who's potentially grant funded, who potentially works with one of the existing organizations, but is then able to connect those detached or isolated community members to one of the other organizations and make sure that they have opportunities to remain involved is certainly an important recommendation that emerged. Yeah.
That was a really great presentation. I'm wondering if you could speak to the differences between provinces, if they exist.
Yeah, that's a great question. We need to complete the analysis still in terms of comparing province to province. I think what we really sought to do is extract similarities or ways that we found strategies or innovations that could be translated to different capacities. Something I may speak to is greater concerns related to decentralization in Albertan provinces. I think part of the concern was also having fewer interviews in certain of the provinces. So Saskatchewan, for example, 2 communities, but in total only 3 interviews. Whereas in British Columbia, there was the opportunity to go much more in-depth in some of the communities. So we had some with up to 9 interviews from a single community. So I think lack of data from some of the prairie provinces would make it a bit more challenging to draw those direct comparisons. But absolutely, that's something we'll be looking as we move forward with the analysis, for sure. Harsh. I was born in Moose Jaw. All right, thank you, folks.
Thanks so much. We'll have our next group come up. And just a reminder, if you do have a question during the discussion period, just raise your hand so we can get the mic to you to make sure that the live stream audience can hear your question as well. Thanks.
Hello, everyone. My name is Michelle Smith. I'm a regional practice lead in the research department at Interior Health, focused on long-term care and seniors care. And I'm here to support my lovely colleagues here who are amazing. I learn a lot from them. I highly respect them both personally and professionally. And they've been at the core the entire time of COVID, wildfires, floods, heat domes, everything, staffing shortages. So I'd like to introduce Brent Hobbs, our Director of Transport, Access and Flow in Interior Health, and Dr. Diana Peters, the Regional Medical Director for Long-Term Care, and also a family physician who supports and cares for our seniors in our long-term care. And I'm looking forward to, and then she'll bring your story. So, come on. Yeah. What am I talking about?
Hello, everyone. I never would have thought we would be here or have so many stories or lessons to learn. Like everyone, we thought it was just going to be a fire or a couple of experiences. Little did we know we were weeks and months into this. We represent a very large team in Interior Health and a much, much larger team across the province. This was an unbelievable experience, and I've actually experienced disasters in Alberta as an emergency physician, and this will be a lifetime experience to reflect on. This is a real picture of, it appears a wildfire on the Coquihalla outside of Merritt. This was what we were evacuating from. So when we are talking about all of the things we're going to be talking about very quickly in the next 10 minutes, which seems impossible to summarize it, we want you to remember that this is what we saw in where I was living, both from my house, but also when we went into the communities to evacuate. And often what we were driving through was fire, smoke, and a few other issues like a burning truck on the highway. So I'm going to let Brent take over. He's a much better speaker than I am. And then we'll be taking questions later.
Thanks, Diana. Just a show of hands, how many of you were directly or indirectly impacted by the fires last summer? Holy cow. Well, on behalf of Interior Health, thank you. And also, yeah, thank you. I also just want to warn you that this could be fairly triggering for some in the room. It seems to be a theme that's resonating with all of us. We also want to respectfully acknowledge that the fires and floods of 2021 impacted the traditional, ancestral, and unceded territories of the 7 First Nations in Interior Health, which is also home to 15 chartered Métis communities. And it is with humility that we learn from them. We continue to strengthen our relationship, and we did a lot of that relationship building through these disasters. We have no conflicts to declare. So this is Interior Health. How many have come here? This is your winter and summer playground. How many have come to the Interior for summer or winter activities? So it's a rural health authority. It's the size of Oregon State or the United Kingdom. It's home to 780,000 citizens. And it is very rural, very rugged. You have to travel a long distance to get to the right care in the right time on a good day. And this is our highway system. They're also now known as our escape routes. That is how much of Interior Health was impacted by the fires starting June 30th with Lytton and ending at the end of August. 48 fires impacting at least a dozen communities and some 34 healthcare facilities. And this is where all of our patients in the hospitals and our residents and the clients we have in the community, this is where we evacuated them to over a short period of time. And so as far north as Prince George and Quesnel, as far south as Victoria, a dozen facilities in the Lower Mainland, and everything in between. And the people in 100 Mile House, you can see there the red lines, they were lucky enough to be evacuated not once, but twice in the summer. So it is a massive, massive undertaking. It was unprecedented, and here are the impacts. But I just want to highlight a few key facts here. There were 304 evacuation alerts. So what an alert means is the authorities are telling you, you need to be prepared to leave in a moment's notice. Or you can stay and you can live at risk. And there were 181 actual orders. That's where the RCMP is telling you, you must leave. This is an order. Now, we had 20,000 citizens who were evacuated, and of that 20,000, 2,000 were healthcare professionals. So you lose 2,000 members of your workforce, you can't staff a hospital or a care home. So just setting the stage. So the key take-home message is, one does not make a decision to evacuate in isolation. So the gold standard, and this is our practice in BC, is to strike an emergency operations center. This is a generic org structure, but this brings together all the major business functions of an organization. So operations, human resources, finance, clinical physicians, right? With senior leaderships and liaisons with other agencies such as BC Wildfire, the RCMP, so that all of your efforts in a command and control structure can be coordinated, so we avoid silos and we have seamless lines of communication. In reality, it's really chaotic, but this is controlled chaos. This is a controlled chaos organization structure. And you heard our keynote speaker this morning. We're just going to see more of this, so please sign up and take a course through Health Emergency Management BC. So the question is, do we stay or do we go? That is Lytton before the fire. That is Lytton after the fire. So we're balancing the risks and the benefits. So the first one is the complexity of care, looking at the clinical needs and the mobility needs of the client. the more complex they are, the more we should prepare to move those patients early. So if you're a total care patient in a long-term care, they're the first to move. We look at the threat to the infrastructure. If we don't have sewage or potable water or clean air or power, that facility is not viable. We must evacuate. We look at the proximity of the threat. Is it close? What's the weather forecast? Is it going to rain in a day, or is there lightning in the forecast? So all of these are triggers to move early. And then what is our distance to safety? What may be on a good day a 4-hour trip may in a disaster be a 12-hour trip. And so you need transportation resources. In a rural setting, they're one ambulance towns. We do not use the ambulance service to evacuate patients if we don't have to. So we mobilize buses, transit buses, the Northern Health Connections bus, stretcher vehicles from urban centers, and we deploy them in a convoy to these communities. Staffing. We need staff to provide continuity of care at the sending, during transport, and at the receiving site. And patient risks. Moving patients is not without risk. Risk of falls, risk of delirium, risk of soft tissue injury, especially with long evacuation times, and the emotional distress for our patients and for our staff. So what did we learn in real time? We learned with each fire, we debriefed each event. Mobilize your interdisciplinary team early to coordinate the evacuation. So we would send physiotherapists and respiratory therapists to the site to coordinate oxygen tanks, to do mobility assessments, and to get the patients safely on the buses. We created standardized transport medication kits with all the tools and medications to deal with side effects in transport, like nausea, pain, anxiety. Transport captains. Can you imagine being a long-term care nurse having to evacuate 150 frail elders and coordinate this activity? Not possible. So we learned very quickly, mobilize a paramedic or a critical care nurse that knows the transportation system to the site to coordinate that activity. And then tracking systems. How do you track 500 individuals in 12 to 24 hours? How do you do that? And our systems don't talk to each other, even within our own health authority. So we developed Excel spreadsheets. That's all we have. So that's, right? And then you're expecting people to be experts in Excel, but we got better at it. But there's 3 things you need to know. Stretcher, wheelchair, or ambulatory. We got it down to those 3 things plus the demographics. So best practices in the literature, very quickly. Anticipate and expect the unexpected. Make sure you're practicing and doing mock trials. Standardize your processes and take all those factors we talked about and stratify the risk, because moving frail elderly patients is not without risk. Clear lines of communication in a command and control structure like the EOC, and patient tracking and identification. At a minimum, every patient needs to be identified with a wristband. And so what we're doing as a province under the leadership of Health Emergency Management BC, we're taking all of these learnings, all the feedback from all of our partners across the province, and we're standardizing our approach. Everything that we've learned from the literature, we are applying. And again, we could not have moved over 1,000 people without your support. So on behalf of Interior Health, thank you to all of our health authority partners, our transport partners, for supporting our patients. And I would like to say, let's hope we don't have to do this again, but we probably will, and let's just be better prepared. Thank you.
I'll just quickly say, because I know the questions are really for these two. We're as part of the process for lessons learned is looking at these questions, perspective of staff, family, physicians, everybody in the interior health, the community. So we just want to put a bit blurb up there, and that's what we're working on. And then ask away to our
Thank you. As a resident of the interior, I can say unequivocally that your intervention saved lives and made people's lives better. So we appreciate the effort that you brought to work every day. I was wondering if you could speak to some of the challenges associated with the destruction of infrastructure related to things like highways and communications, and the difficulties associated with not only having to move these patients from where they live to another location, but to do it across broken highways, broken airwaves, flooded rivers, etc.
I'll take part of that, and then Brent, our transport guru, will finish that. So I can say with certainty that things were changing hourly. Maybe if we were lucky, within days. The highways and infrastructure were critical to how we made decisions. Fortunately, we did have and had built very quickly relationships. So we were trying to build capacity medically and operationally. And we were, I think, and it's not easy to explain this because it was, we were on phone calls and Zooms, 24 hours a day, Bob? Like, honestly, it was, you do the best you can, but the challenges are real, and I think we've learned to expect the unexpected now, which means we're going to we have maybe secondary plans and third layer plans. Some of the things we learned was the leadership has to be there, and the leadership has to be on both sides and in the middle. I specifically went on a transport because of the perceived need that it wasn't an organized need. It was me just saying, I'm going because I have to. And what I can say is, thank goodness I was there just to make those decisions in the moment with the nurses and the care aides that were really in a several forms of shock, right? Along with the residents. So I would say, along with Dr. Dodd, that you need to have leadership. You need to have capacity, planning, and communication. And even when the road becomes blocked with fire or floods, you need to have a plan. The other aspect is understanding the medical needs of the people you're transporting. And one of the lessons learned too, we can all giggle at the Excel sheet, but that Excel sheet is probably what helps save lives. And if I have my wish, that Excel sheet needs to be much more developed and be a part of a transport and be the Bible of the transport. That will save more lives next as we get into more and more disasters. Anything else? Did I cover it?
I just reinforce, Michael, the importance of the Emergency Operations Center structure, because the unexpected is going to happen. So you just need to quickly link up with all the right people. So if you lose a highway, which we did on multiple occasions, or a bus breaks down, who can in our organization can connect with RCMP, Wildfire, BC Highways to find us a different route?
As I think about or reflect on the last year, I'm from Vernon Jubilee Hospital, sent patients your way, and maybe we took them back a little slower than you wanted, but we got them back. My hesitancy in being prepared and teaching staff to have their go bags and stuff is that triggering piece. We got to lean into it, and I'm going to take the speaker this morning, and part of that preparing is to address the anxiety. So that added layer. So how can we, what's your advice on how we can be thoughtful that some of the staff aren't going to want to prepare?
So I've had a few careers within my career. I started off enjoying my hair being on fire. I was emerge obstetrics and surgical. And I can say when you work in acute care and some of the more busy acute aspects of acute care, you're trained to deal with stress. And I don't think an emerge nurse is at all stressed by a to-go bag. I think a long-term care nurse is stressed by a to-go bag. We have to address that, how we've basically siloed our expectations, and we have to really acknowledge the climate change, the risk of how we have built our long-term care centers, how we've staffed them, assisted living, even our community services, And we have some of the most critically vulnerable people with innumerable social issues, and we have no idea what those numbers are and how to address that. That alone is stressful. As a family physician, being told to collect the number of people that I think, and it's graphic, that I think will die if I don't put them on a list for evacuation because they're stuck in their apartments and they have no transportation and they're connected to an oxygen concentrator, not a tank, a concentrator. That is stressful, right? Again, long-term care nurses, they go into long-term care not because any emergency is happening. Their emergencies are to palliate and comfort and not grab, go, right? So we debriefed a lot. When I transported, I debriefed, and we continue to debrief. We had a lovely communication. The physicians in Fraser Health and Coastal, I was on many chats, and I think part of it was exchanging information, very critical. I would say that's a learning opportunity, but also is an opportunity to say, how are you doing? Right? Can I help? Do you need to talk? Can we check in? They were checking in with me a lot, right? That was great.
Like Jeff said in the video, you know that black box over there? Not prepared to open it. And
Yeah.
thank you yesterday for opening it.
Yes. Thank you.
Hi, thank you very much. It was just a wonderful presentation, very impactful. My question is for Brent. You talked about the PDSA cycle in learning, and it really is at the heart, of course, quality and quality improvement, but also in thinking about learning health systems and using, of course, research as part of that process. I'm wondering if you can comment about how that experience and a learning health system might be used as you plan moving ahead for any of these events that we know we will have to be dealing with moving ahead.
That's a very good question, Dee. I think, well, we learn in a team environment, right? So, and we don't have to, we're not the experts. We're sending you the patients. And we have lots of experience to share, but I think it's important to listen to the perspectives of everyone that was involved, right? And in BC, we live in a very unique context, right? Compared to like war zones where a lot of the literature is from, war zones and hurricanes. So there is not very little in the literature on evacuating health facilities and wildfires in our context. So I think there's opportunities there. So I would say collaboration, learning, debriefing as part of your EOC structure. That's all we had time to, because we were just reacting every day. But we had to stop and reflect and go, okay, that last evacuation didn't go very well, right? And people want these lists to be tighter, right? And so, like, for example, we can't expect long-term care nurses to be experts in Excel and manage patient lists. So, okay, what can we generate for them centrally, right? So it was that feedback we just learned each time and tried to improve our response. And we really didn't get an opportunity to really debrief until after the floods, right? Because I could tell you, like, so June 30th, we were prepared before June 30th, by the way. We knew that there was going to be a big fire. It was just inevitable when you're in 50 degrees in Lytton, it's going to happen.
There was already fires.
There were already some fires. So we knew we had an emergency operations center already struck. Then you had the fires from June 30th to August 31st. Then we had to repatriate everyone. That was another 2 weeks. And not the day after that, it was, Brent, are you available? And this is a Saturday, right? We've got Delta. We got to get people out of Northern Health. We need to bring them into our ICUs because their ICUs are overrun. So just kept going and going and going and going. And then November 17th, 16th, call from the ambulance service Monday morning at 7 o'clock. This is how it went. Brent, major flooding. Don't know how significant. We're cut off from the lower mainland. Waters are rising. We fear lots of drownings. Princeton, Merritt, we can't help you today. And I went, is this April 1st? Like, are you kidding me? Right? And so because we had done this learning through the summer, we were able to put that plan into action. So it did help. Yeah, through that Yeah. Yeah.
And I know that you guys just so graciously thank the rest of us in the healthcare system for taking patients, but I also do want to acknowledge that in the scope of what we've all been through, Interior Health has borne a huge brunt of this in a very big way, and I just want to raise my hands in gratitude to you guys for, I know, the countless hours, the dedication, the times with your family and loved ones that you've given up to keep clients and families and residents safe in this province, so thank you for that. Thank you. And now for our final presenters.
Hi everyone, thanks for joining us here today for our presentation. It actually flows very nicely from that previous one because we'll talk a bit about how our division fits into the EOC that team presented on. So I'd just like to respectfully acknowledge that the land on which the three of us traditionally live, work, and play is located on the Tecumloops to Secwepemc, and we're also grateful for the host nations for having us here today. I'm Chelsea Brookes. I'm the Practice Development Lead at the Thompson Region Division of Family Practice, and joining me is Rhonda Eden, Director of Programs and Partnerships, and Dr. Graham Dodd, who's our Board Chair and Physician Lead on the shared care project that we're going to be talking about. So to give some geographical context, our division represents primary care providers in Kamloops, Chase, Logan Lake, Sun Peaks, Barrier, and the North Shuswap. So we're smack in the middle of the interior. We have no real disclosures, except Graham's just telling you that he's the lead and board chair for our division. A super quick presentation outline, and over to Dr. Dodd.
So thanks very much. Great presentations, right? And I think that it just shows, and one of the points I wanted to bring up too is that one of the things we forget about as healthcare providers in a disaster situation is that we can often be both victims and responders at the same time. And so you asked that question about how do we build resilience in our healthcare workers, et cetera. And I think it's just sometimes acknowledging that. I think we've all now been in situations where, you know, you are being called. I got started in Salmon Arm in '98 evacuating a hospital, but at the same time, exact same moment, my house was being evacuated. And so, you know, I actually had to physically go home because I couldn't phone, call, get a hold of my family at home to find out what was happening. And it got to the point that I could no actually longer work because I was worried about what was happening. So it goes to that point of being important. I've given talks on disasters and emergency management for the last decade or more, and I usually have to start by explaining to people what a disaster is. And I think, you know, not only have we seen it over the last couple of years, there's been some excellent presentations. If I gave this talk 3 years ago, there would be generously 5 people in the room here. But, you know, now we have a room full of people interested in this topic. So just 4 things I talk about disasters is that they are predictably unpredictable events, right? We know they're going to occur. We just don't know what they are or when they'll occur, unless you live in the interior and I know we'll burn again, right? The other thing about disasters that's important is all disasters start locally. So they involve the local community, the local providers, the local families, the local hospitals and staff, okay? All disasters begin locally, then they spread. And what defines a disaster is when your capacity to manage becomes overwhelmed. So in other words, all disasters are relative things. All disasters, number 3, all disasters involve healthcare and healthcare workers, right? And so they may be in the acute phase, it may be in the chronic, long-term phase. I visited Christchurch, New Zealand 5 years after the earthquake. There are still folks that are afraid to go downtown because of the post-traumatic stress that came from that event. Who manages that? The family docs in the community, okay? So all disasters involve healthcare. But on the other hand, the last thing, all disasters create opportunities, right? So one of the things we think about traditionally with disasters is we focus on our facilities, our hospitals, we focus on our health authorities. But one real opportunity that's come up is what is the role of family docs in the community? So large communities like the Lower Mainland, what's the percentage of family docs that are attached to a hospital? It ranges from 0 to maybe 2-3%. So there's a huge capacity in that community. So what we're going to talk about, and I'll let the much more esteemed people in my team talk about it, are the roles in which divisions can play, and what our division did and some of the tools that we created to help other divisions. Okay, so thanks for having us, and I'll let the more important people talk.
I don't know about that, but yeah, so we're just going to start by talking a bit about the goal and provide you a little bit of context. So Graham had some forethought long before the pandemic about this topic, and including community primary care providers in emergency planning and response. And so in 2018, our division was able to obtain funding through shared care to actually look at this work with 3 sort of objectives. How do we support our members? How do we partner? And then how do we also work with community? So the main goal of the entire project really is to take that collaborative approach to support primary care providers during crisis and enabling that continuity of care. So I'm going to stop talking physically, and now I'll let you listen to me talk. But really what we want to show you is a video today and tell you the story about Dr. Mo, who's one of our rural physicians in Logan Lake, who was evacuated during the wildfires.
Dr. Mo runs a family practice in Logan Lake, and she is one of the family physician members at the Thompson Region Division of Family Practice. Rhonda Eden worked with Dr. Mo during the wildfire crisis, partnering with Interior Health to support Dr. Mo personally and to keep her practice running so she could see patients. I'm here today with Rhonda Eden from the Thompson Region Division of Family Practice. Rhonda, you remember the events of the Logan Lake wildfire evacuation last summer very clearly.
Yeah, it was emotional for both of us, and even when we talk about it now, we also both get quite emotional. When she did call me and ask where she was going and what she needed to do, we had originally planned with the health authority for her to go to Merritt, and in that moment, she was being told to go to Chilliwack. So we really had to put an action plan in place, and so had to make a few calls. I was traveling back from Vancouver at the time, so pulled over on the side of the road and called the health authority to make a plan B if need be.
There's a lot of confusion during an evacuation.
I think there is, and when you're supposed to be going to Merritt and now you're supposed to be going to Chilliwack and emotions are high, it's quite difficult. But with that partnership with the health authority and after just a few calls, we did confirm that she was able to go to Merritt. By the time she got there, we had a hotel in place for her and meal vouchers, and also had an office set up for her at the local hospital that she was able to then get into on the Monday.
That was a stressful time for her. I'm so glad that the division was able to support her.
Yeah, and I think it was incredible that it was so critical for her to continue to practice medicine, and that by Monday she was able to still see about 85% of her patients. And we've heard from a number of people that that was just so amazing that she was able to do that and still do referrals and do prescriptions and follow up with her patients.
Given everything she's been through, does Dr. Mo have an emergency management plan in place for her clinic now?
We're building one now. And if she were here today, she would tell you that one of her biggest learnings from her experience is to be better prepared next time, both personally and professionally.
Thank you for sharing your story. It really speaks to the power of what partnerships can do.
There is so much power in partnerships. The division has a formal incident command system that ties into community and interior health systems. That allows us to effectively communicate and support our providers. The bottom line is that these partnerships and emergency planning allows providers to continue to practice medicine even when they're impacted by an emergency.
Thanks, Rhonda. We're always happy to talk more. We have resources, so reach out to the Thompson Region Division of Family Practice. So these were the two key results we alluded to in the video. I know we don't have much time left, so I'll just quickly skim through before passing it back over. This morning, Courtney said that action alleviates anxiety. So we created two practice resources a guidebook and an associated workbook for healthcare clinics to be able to complete, to have a bit of a plan in place. And it covers the main components around evacuation, shelter in place, incident recovery, and then practice and review, including debrief. And we partnered with the Kootenay Boundary Division on these, and were inspired by the Victoria Division's resources. And our membership's been very excited about them. We've engaged with about 80% and are just sort of in the process of getting people prepared for this, hopefully not upcoming wildfire season, but very likely.
Thanks, Giles. I do need to take a bit of time to talk about this, because this is where I think the magic starts. And so, you know, to speak to Brent's presentation, so our incident command, the Blue Bubble, TRDFP, we connect in with our members through subsectors. And so we've taken our region, we've split it up into five subsectors, and when needed, we have a staff and a physician lead that's actually making contact with those networks. During COVID, we connected weekly for almost 10 weeks. So then we can take that information to our board and our health leadership committee, but more importantly, we take it to the Health Authority's Incident Command, where we sit every morning for the debrief. We don't get work done there, but the work then is taken away from there. So sub-working groups and various bits. We also connected in with all of our 8 divisions within the interior, who also meet on a regular basis during an emergency, and then connect in with the regional emergency operations center for the health authority as well. So things like the long-term care piece, and so we hear about that at the incident command, then we say, okay, where are people coming from? Okay, we have a bunch of people coming from Kamloops. We get in touch with the division in Williams Lake. We also get in touch with our physicians. We find most responsible physicians so that there's a proper handoff and care for those patients when they come. Dr. Mo's story, direct result of sitting at that. PPE during COVID, there. Testing sites, vaccine clinics, like all of the things, the magic started at this place. And I'm super excited that now provincially GPSC has also recognized this, and so there's some funding now for divisions to connect in with their health authorities and also create their organizational plan. So very proud work of that, yeah.
We showed you the one video. We'll have another one on our website soon, just sort of about how clinics dealt with like a flood or an armed gunman across the street, sort of those smaller scale emergencies. And smaller scale emergencies, but major impacts. And now over to Graham for next steps.
So where do we go from here, right? And I think that's the real question, right? We have a captive audience. Everybody's interested in this topic. This last couple of years has created opportunity, right? So how do we harness that opportunity? So one of the things we need to think about in next steps is how do we develop that leadership capacity, right? I think that's very important. You don't hear about emergency management in medical school if you were trained in Canada. And so how do we get physicians interested in this, specifically medical leadership? So where do we go? So we have to sort that issue out. And then we have to actually sort out the issues that if you're a medical leader in this situation, how do you create capacity in your own self? How do we spell off things? I learned from example, it's very hard to be on call 24/7 for 2 years in a row, right? It burns you out. So how do we create that capacity and get our other colleagues? Networking. You know, one of the biggest things that happened was, we alluded to it with the EOC, but that relationship between divisions and our health authority, in our case, the Interior Health Authority, was key. We became partners in this journey, right? And I think that was really quite something, right? We became part of their EOC, they became part of ours, right? So that networking was really important. And integrating those lessons and integrating, the opportunities throughout. Collaboration. We worked on multiple projects. A good example is our respiratory assessment clinic, right? It started with an idea. It started at the EOC. We needed to combine both the resources of the health authority and the division to create those. And then we could share those out across not just our region, but out throughout the province as well, right? So it's change management. Disasters create change, and disaster management is change management. And one of the most important things we've heard throughout the last couple of days is the concept of resilience, right? So when we think about what is resilience in a community, and it's not about bringing a community back to where it was before the disaster, it's actually bringing it back better. So it's taking those lessons that we've learned, right, and applying them and creating those lessons with sustainable knowledge, right? You know, we're all prepared for the heat dome if it happens in the next 1 or 2 years. But if the heat dome doesn't happen for another 5 or 6 or 8 years, how prepared are we going to be then, right? So it's about taking those lessons and sustaining that knowledge, right? And sustaining those relationships. So that's the last slide? Okay. So, yeah, that's really what we wanted to do. This was an example of how one small little division could work on a project. We didn't create the fires or the floods or the COVID, even though our project started beforehand. But it created opportunities for us to build better relationships, right? So we're happy to answer any questions. Thanks for your attention.
Thank you. I have a question. I had a little bit of exposure in Nicaragua. There's a military hospital, and every time that there's a disaster, they have like extremely well trained and they know what to do, fire, volcano, hurricane. What's the military component here for BC? Like, what's the relationship? How does it work?
Actually, Brent may be able to answer that a little bit more just because your connections is transport, right? But you bring up an excellent point. We all remember the Humboldt bus crash? Mm-hmm. Okay, so one of the key things that happened in the Humboldt bush crash, of course, that's a rural community, right? It would have overwhelmed any small rural community. But the physician that was actually on duty that day was trained in Syria, right? So he went, I've done this before, right? If it was me, a Canadian trained physician, maybe different, right? But good question about the military, because we all think the military is there to suddenly help us all right away.
Yeah, and not my area of expertise, but again, going back to the Emergency Operations Center, so it was set up for interior health, but it needs to be linked with this network that Graham alluded to other agencies. So back in 2017, there were 5 major fires up and down Highway 97 between Ashcroft and Williams Lake. And the town of Williams Lake was completely cut off, surrounded. No one knew what was going on. People thought they were going to burn to death. It was frightening. And ambulances don't fly in those conditions. So we said, we need the military. How do we get the military? So we started doing some brainstorming, right? So through the EOC structure, our lead agency is Health Emergency Management BC, and I think, Scott, are you here? Yeah. So through that group, so every health authority has that leadership. They are experts, and they are plugged into the provincial system, and it's through the provincial system that we can access military resources. So on that night, I'll remember it for the rest of my days, a Cormorant helicopter flew in and did a milk run between Williams Lake, 100-mile Ashcroft, took all the patients in acute care and ferried them to Kamloops. But that's how we would link them in, is through the EOC. Great question. Yeah. And we don't have volcanoes. We do have volcanoes? I was thinking about that.
Well,
right?
I don't know. Mount Baker's kind of quiet, right? Not just to say, just bringing that up.
Quick question, and might be for Brent as well. Maybe not. Maybe you can answer. So local government. That's my lens here. That's my previous life, but they're responsible for emergency management for the residents of the region. They develop EOCs and they go through all the training, and I have as well. Can you tell me how you liaised with local government EOCs? I'm just kind of foggy on the whole EOC thing and the structure and how that worked, please. Thanks.
So in the last year, I would say direct contact from divisions into community. That's sort of like one of these kind of next step pieces for us. So we've started having conversations with our rural communities around that. So the Village of Chase actually just updated their emergency preparedness and response plan. And now alongside the Health Authority Division of Family Practice, our division, because that's where our members are, we will be one of the first point of contact as well as healthcare, and then we will determine the need for whether divisions need to sit at their incident command or whether we can do that work through the health authority. So again, just building on those partnerships. And that's what the hope for me is, that will be what happens in the rest of our rural communities. Yeah, for sure. And then we'll tackle Kamloops, our urban community, after that.
Yeah, because I guess the whole emergency management is exactly the same.
Yep.
They have the same hierarchy, the same thing that Brent has just pointed out. There's a lot of there should be a lot of well-trained people in those municipalities and that understand the language. So I just was interested in that. Thank you.
I think for us, part of the power in connecting in with our rural communities is that we actually have connections in with what we call community health tables, so community leaders in wellness and healthcare that come together. And so we brought them into our fold during COVID and had some community meetings, and that is how we ended up getting the connection in with the Chase Village, is because we'd had that connection in with the community health table first. Yeah, so power and partnership.
But you bring up a good point, and you say people understand and share the same knowledge and the same language. The group that doesn't have that language or knowledge are physicians, right? And so here's again an opportunity as we think forward. How do we build that in? Because we know healthcare is going to be involved. So how do we build that in and make that connection?
Sorry, just a very quick comment. So interior health team, unbelievably awesome, and you're giving me kind of PTSD a bit from going through this again, but you guys did an unbelievable amount. The critical piece was getting primary care into the EOC structure within the health authority is one, but your last comment, Graham, about the physicians not knowing, the other group that does outpatient care is community-based specialists who aren't affiliated with the health authority, and just putting to this group, that's a gap as well in being able to self-organize, because the divisions do a fantastic job, but it's part of their role in the times is keeping people out of emergency departments and a substantial proportion of care that's also in the community that don't have a direct line or privileged by the community as well.
That's a really good point. So community specialists, but also groups like community pharmacists, et cetera, right? I go back to the New Zealand example because a lot of my sort of knowledge and experience was working with them. And, you know, one of the things that worked for them during the 2011 earthquake, and so this would be similar to our division, this was in Christchurch, New Zealand, and their mandate was they were there to save the hospital. So what that means is the community, as community providers, recognizes that not everybody needs to or can go to a hospital that is already overwhelmed. Don't forget, when an emergency or disaster happens, the hospital is already overcrowded and overbusy, right? You know, because things like heart attacks and stuff don't really stop, right? So how do you offload that? So how do we, you know, recognize the role for community specialists, community family docs, community pharmacists, etc., you know, and make them part of this. But we have to do it ahead of time, right? That's the planning piece, right? You can't do this suddenly with a last-minute call, right? And so we were incredibly fortunate to have taken the COVID experience and then be able to apply those same relationships to the wildfires, to the floods, to the COVID, to the floods, to the COVID, you know, and as we move forward, right, to the next wildfire season. And just remember that last year at this time of year was wet and rainy like it is now, right? So we will burn again, right? But we will also be more resilient with each time.
What I can say, Devin, though, is with our practice resources that we've developed, so we've actually engaged with community specialists on the development of those, and we will be adding them into the fold of our engagement, into at least hopefully getting them sort of personally prepared with their office. And then the videos we'll also share with RIPA and pieces like that. So slowly, bit by bit, making those connection points also, yeah.
So as Jason told us yesterday, we're only 2.5 years through this 5-year pandemic. And as Courtney told us, we really need to make sure that we are creating resilience in our system for climate chaos that's coming at us. So just a huge, join me in a round of applause for these teams who are creating resilience. Thanks so much to all of you. Please make sure you fill out your evaluations. It's really important for us to continually improve on our sessions and the layout of the conference. Thanks, you guys.